So I would just like to thank the organisers for asking me to be a member of this stellar sort of rock star list. My links go back almost 30 years actually to Professor Alana Crome. So I arrived at the Maudsley as to do a locum, and had the luck to be given a locum job in drug addiction ward where Alana was the consultant. And so at that stage I wasn't really interested in addictions, but obviously, as you can see, this has now become my career. And the reason I want to mention that is I think for the trainees listening is that you often never know what opportunities are going to come your way, and what you may be going into a post or a job which isn't particularly interesting to you, and suddenly you find yourself hugely interested by it. And that's what happened to me. So it did start many years ago, so it feels fantastic. 30 years on, I would never have predicted I would have been speaking today on this subject with, with Alana still part of this journey. I'm going to touch on many of the themes actually been mentioned about parity, about looking at the longer term view. But next slide, please. I just wanted to mention about my disclosures. A lot of my work is in pharmacological area. Just wanted to point out that most of my research funding comes from the MRC and NIHR, with some from GSK and Lundbeck, which I'll mention. But most, if I do take any monies, it goes into my university or discretionary account. So next slide, please. Just want to focus a little bit on what I'm going to really talk about today in terms of where my focus will be, which will be really at the bottom sort of right-hand side, the spiral into addiction, which does affect the smaller number, but does really for most of us in our day-to-day clinical work is our most challenging group of patients often. We know that the majority of the population will try a drug, that big circle on the left, and it causes no or limited difficulties. But a few people start to use drugs or alcohol more regularly, and so just liking a drink or a spliff of cannabis shifts to a need but that happens in fewer people. But actually, this is the population we're now worried about with the impact of the COVID pandemic. A lot of people who had high levels of anxiety and depression were using particularly alcohol because it was still available. You remember that alcohol or off licenses became an essential retailer very early on in the pandemic, which I think is telling in itself. And the key switch really is about the lack of control. And the people, when they start to drink or take a drug, have no control over their consumption. And so it escalates into such a heavy use where you then get the physical and the emotional adverse effects from it, but also all this sort of drug-seeking behaviour, etc. Next slide. And I just wanted to emphasise the range you've got right from public health, the sort of population level, really through primary care to specialist addiction services, of which where I work currently as a consultant in London at CNWL. So you've got a huge range, but because of the audience, I'm going to focus a little bit more on the specialist end, but also therefore those that might be in a psychiatric teams, and therefore that is the people who have an addiction. And what I mean by that is they have lost control, they lack control of their consumption now. So they may be drinking or taking drugs every day, or they may be doing it intermittently, but when they take a drug, it is out of control. Next slide, please. So I was asked to talk about sort of neuroscience. Well, for me, I guess coming from a neurobiological, pharmacological background, clearly we need to understand how the brain is working. This is not to minimize the impact of this, the environment, social milieu, and the importance also of psychological therapies. But of course, psychological therapies, psychosocial interventions will also change how the brain is working. Starting on the left-hand side, you may be thinking about pre-existing vulnerability. So this is why taking a history, knowing the family history, and knowing the age of when they started consuming. A 13-year-old consuming heroin is going to affect their brain very different from a 33-year-old because of the brain's plasticity. So it is important to understand the impact that may have had. We then need to understand the impact of their drug exposure, what compensatory mechanisms there might have been to maintain brain function. But actually, more recently, we've been looking a little bit more at resilience, i.e. what may protect now that's obviously quite a harder group to study, but I think we are beginning to understand all of that. Because then if we shift into the right-hand column, we're looking for recovery that is sustained. But unfortunately, most of people who become dependent or addicted to a drug or alcohol will go through cycles of remission and relapse. That is, in a sense, the norm. And you know, thinking about Helen's talk a little bit, it is the longer term view. I've known many individuals who struggled a little bit at the early, and then something changes and they then get sustained recovery. And I think that is very pleasing to see, but sometimes it does take a few cycles. And we need to understand how we can improve brain function, or at least ameliorate any dysregulation. Because without understanding that, I think we're going to really struggle to change care substantially. And that's a little bit of what I'm just going to focus on now. Next slide, please. So my group, with David Nutt, I've worked with David Nutt now almost actually I've known David 40 years. So he was a tutor when I was a medical student. But we set up this platform to really understand the bit about the neurobiology of relapse in addiction. And I'm just using it as one example about how neuroscience can inform development and treatment. So it was in partnership with Cambridge University in Manchester. And what we set up the ICAM platform for was to utilise not only the infrastructure, so imaging or MRI scans, but also the clinical services. So we recruited patients from these three quite different areas of the country. We wanted to use neuroimaging, but also cognitive tasks to understand brain responses to three processes we believe important in relapse, which is reward, impulsivity, and negative emotions. We were also looking at three particular modulators. One was the dopamine D3, because of the huge amount of preclinical evidence suggesting this receptor system is important. NK1 was substance P system, again, based on preclinical evidence showing this would be important. We also put the opiate system in, naltrexone, because naltrexone can be used and is used in relapse prevention work. So in a sense, that was our gold standard treatment option to see how that was modulating these systems. So next slide, please. What we did was, and I'm just going to focus on the reward system and show you. So the reward system, as I'm sure you're aware, is the dopaminergic pathway, the mesolimbic pathway from the brainstem going up into the ventral striatum or the nucleus accumbens. And the sort of gold standard task that is used is something called the monetary incentive delay task. It's been used in multiple different neuropsychiatric conditions to understand how this reward pathway is functioning, because it's fundamental to our survival. It's what gets activated in natural pleasure rewards. What you can see here in the black box with the symbols is that depending on what symbol you were seeing in the scanner, that would either predict you were going to win money or lose money, or it was going to be neutral. And you have that between the cue and the delay, you see the target come in that star shaped. If you'd seen the uptick, so you knew you were going to likely to win money. And that means that your reward system was being activated, and that's just shown there on the image of the brain. So those red and yellow blobs are where the activation is seen in the ventral striatum to the anticipation of winning money. So it's the thought of winning that is very potent in activating the ventral striatum. So we took this task and we applied it in our ICAM study. And in what we did in ICAM, because we were actually trying to set up the platform, we actually recruited people who were already abstinent and stable in their recovery, because of course we didn't want to necessarily interrupt that by having to undergo all these scans and interventions. So we recruited abstinent people, and we then run this whilst they were lying in the scanner and see what happened. Next slide, please. So what we can see here is in that brain slice in the blue blobs, that's the ventral striatum. What we can see in the graph are three bars. One is from healthy controls, HC, AD is abstinent alcohol dependent, and the PD is abstinent polydrug. Now, what we had hoped in this study was to compare alcohol with heroin and also with cocaine, so three distinct groups of addicts. But as I'm sure many of you who work in the addiction services or have worked with people with an addiction issue, actually it's very rarely one drug. We could find relatively pure alcoholics, but we could not find a pure heroin addict. They'd also had substantial histories, usually dependence at some point in their life, also on cocaine and also on alcohol. So we had a polydrug group. Now what you can see from the bars, so this is the response to winning money. So the healthy controls have a pretty good response. but the abstinent alcoholics are blunted in comparison, as is the polydrug, and that was significant. So these are abstinent addicts who actually, many of them had been abstinent for months, few for a few years. They have still got a blunted reward system that is coming in terms of winning money. So this isn't a salient response to their drug of choice. This is to winning money. So their natural pleasure reward system is still under functioning. Now, what does this mean? So it's very good to show this, but does it have any meaning? So what we did, having had their scan, we actually telephoned them at regular intervals for up to a year, and we asked them whether they had relapsed or whether they were still abstinent. Next slide. And what we see here is some remarkable evidence, actually. What you can see in the abstinent group who were still abstinent at 1 year, their reward system seemed to be functioning normally. There was no difference to healthy controls at baseline. So over the next year, they were still abstinent, and you could have predicted that almost, really, given their response to reward anticipation. Whereas those that went on to relapse had a very acutely blunted reward system here. So what you can see here is that, yes, this does seem to have meaning. So if you have a blunted reward system, you are very much more likely to relapse over time. So what can we do to change that? Well, one of the things we were doing with this was to give medication. We pre-dosed with a single dose when they came in for the morning of their scan with those 3 drugs that I mentioned, one of 3. So next slide. So I'm just going to show here the result of pre-dosing them with a single dose of a D3 antagonist. And just to let you know, because it's a presynaptic D3 receptor, this would actually increase dopamine in your system. So we're increasing the dopamine function within their mesolimbic system. Now, what you can see in the grey bars is the pre-treatment really didn't change the activity in the healthy controls, but it did increase the activity in the abstinent alcoholics and also in the polydrug addicts. So what one single pre-dose of this D3 antagonist seemed to be doing was boosting activity in this critical pathway we now believed in relapse prevention. So it would do what you would hope this drug would do. Fortunately, it's still sitting on the shelf in pharma. As you know, pharma essentially pulled out of psychiatry. But certainly from a neurobiological perspective, this drug shows a lot of promise. Next slide, please. I also wanted to show that this is the pre-dosing with an NK1 antagonist. Now, we started off by using a GSK compound, and we're actually now using a Prepitant. So this drug is actually licensed to treat chemo-induced nausea and vomiting. But we know that it's an NK1 antagonist. And in fact, it was the drug that was being developed as an antidepressant and anxiolytic that failed to get a regulatory approval. And so we're now exploring this in addiction. As you can see here, it had no impact on the brain response controls. It increases it in alcoholics, but had no effect in polydrug addicts. So these are exactly the same participants as I've shown for the D3, but you can already see that the neurobiology isn't the same. In fact, we had expected the NK1 to have an effect in the polydrug because the evidence is really strong for NK1 having a role in heroin addiction, but we didn't see this in this response. So it is interesting, exactly the same participants. We're now seeing a differential effect of 2 different drugs, which is important if you think about personalized treatment. Next slide, please. But I mentioned the gold standard drug that we use was naltrexone. We were expecting to see naltrexone to have an effect. And so what you can see here in the bars, so the tall bars, the black and the blue are the control. Again, naltrexone had no effect, but the grey and the red are alcoholics and the brown and the green are the polydrug. As you can see, we got the blunted, but there was absolutely no effect of naltrexone. So we were a little surprised with that. That wasn't what we were expecting because of the evidence that, you know, naltrexone is clinically useful. But in fact, actually more evidence has emerged that because these people were very abstinent, it was likely that naltrexone had missed its window of clinical relevance. So for most, there's been evidence come out of a German study where you have to give naltrexone very close to their detox or becoming abstinent in order for it to change the brain neurobiology. And if you give it late, which is what we're doing here, it's probably not going to have an effect. And in addition, these people were successfully abstinent, so they may have again passed that window. So it may be that naltrexone isn't going to work if you start it late. However, at the same time, we were involved in a study with Lundbeck, with makers of nalmefene. Next slide, please. And some of you may be aware that nalmefene is also an opiate antagonist, but is actually licensed to treat people whilst they are still drinking, with the hope that you can reduce the pleasurable effects of drinking alcohol. And what we show here is when we predose people in the presence of alcohol with nalmefene, the blue blobs here in each of those ventral striatal and dorsal striatal areas, showing that nalmefene does blunt the reward system to winning money. So in the presence of alcohol, we are now seeing an opiate antagonist reduce the brain response to winning money, but you do have to have alcohol in the system. It's not going to work if you're totally abstinent and have a non-salient stimulus. So that is an important understanding that opiate antagonists probably are going to work in conjunction if you've used your substance of abuse. And actually, when you look at the clinical trials, they would also support that. So it's good when you see neurobiology and clinical trials coming together. Next slide, please. But the other huge area of focus has been on the reward pathway, has been in its view in terms of cue reactivity. So cues also moderate this reward pathway, but they are slightly different. What you can see here in the red blobs in the graphs on the left is areas of activation. So what the alcohol cues are doing, or the salient stimulus, is super activating, hyperactivating your normal reward pathway, and exactly in the same areas, the striatum and the frontal cortex. So unlike non-salient stimulus, which was money, alcohol here to alcoholics will increase activity. And what is important in a recent meta-analysis that I show in the blue blobs on the right-hand graph is treatment, whether that be naltrexone or cue exposure therapy, so psychological therapy, reduces the activity also in these key brain areas. So what naltrexone's probably better at doing is reducing alcohol-related stimuli, which is exactly, as I said, what the clinical trials show. So this is important. What it's showing really, next slide please, is when you think of the reward pathway, if you're thinking about the monetary incentive delay or money, non-salient stimuli, the addiction in addicts, the reward system is blunted. So what we need to do in treatment is to get a more normal response, and we need to boost the reward pathway so it does respond to non-salient stimuli. However, if you're seeing a salient cue, you get greater responses, so you need to attenuate. And what's interesting is actually some drugs do seem capable of that. They may boost the blunted system whilst moderating the greater activity C to cues. And that would be an ideal drug, really, in terms of the reward system. So what you may have been taught in MLC Psych or whatever is actually the reward system isn't actually blunted to salient stimuli. It's actually a greater activation. So next slide, please. So I just want to spend few minutes to talk about the neuroscience till I go back to the question about how important it is. So I've really talked about the reward deficiency and the mesolimbic system, because actually that is the system most people think about as the go-to system and the one that's really, really important in addiction. And it is, and I'm not minimizing it. And its role really with the frontal cortex, which has a huge role in impulsivity, compulsivity aspect. But I just want to spend a couple of minutes thinking about overcoming the adverse state withdrawal, because I can tell you as a clinician, the thing I spend most of my time really talking to addicts or individuals with problems with a drug or alcohol is withdrawal and the anxiety, the negative reinforcement. It is often the reason why people have started using drugs and alcohol. So for me, whilst I may talk a little bit about the reward system, but I'm often talking about the adverse system and the negative reinforcement, which is really focused on the amygdala and a whole different array of neurochemicals. So next slide, please. So George Koob, who's head of NIAAA in the United States, has written over many, many years about the negative state and the emotional state. And whenever I was listening to him talk about his animal work, it always made sense to me, primarily working with people with alcohol and opiate problem, because withdrawal is a major issue. So just on the left-hand side, he's got the reward system there, the dopamine. I haven't talked about the muse system, but that's really, really important. That's sort of grayed out, because by the time somebody's become dependent, the stress system now is super activated. And as I said, the key brain area is involved is in the amygdala. And we've got different neurotransmitters. Now, rather than the mu opioid system, we've got the kappa opioid system, or the dynorphin system, as opposed to the endorphin. Dynorphin and the kappa system are really unpleasant. They're dysphoric system. We've got the noradrenaline, which is the arousal system, and the stress system. And all of those neurotransmitters, you can see the anti-stress and the stress neurotransmitters. You can see substance P down there, which is NK1. These are now become the target of interest really for us. Next slide, please. But it's not really looked at very often. So next slide. So over the 30 or 40, sorry, go back one. Over the over sort of my career really, because I did start in the 1980s, and the importance of the neuroscience I think now has been acknowledged, but there did have to be a little bit of work about that. So the 1980s, this was actually Nancy Reagan, who was, when she was First Lady, her thing was really to look at drug and alcohol addiction. And this is a fried egg on a frying pan. This was as sophisticated really as the message was back then. And then Alan Leshner, who was head of NIDA at the time, really persuading not only the general public, but also the government and funders that addiction's a brain disease and it matters. And now we have this really exquisite neurobiology that we understand, and I think a lot of people take it as given that the brain is important in mediating many of the vulnerabilities and impacts of addiction. So next slide, please. So where is neuroscience? This coming back to the question. So it is influential, and there's been lots written about it. And if you look at some of the titles I've put here, and I do direct you to one in particular, the bottom one, the Helping to End Addiction Long-Term Heal. This is an initiative started during Trump's presidency, where it's pouring a lot of money into trying to find how we can deal with their opiate crisis, but also pain. So it's a really helpful website, and I get alerts from it regularly about the latest research going on. And unfortunately, it has been the opiate crisis that has pushed a lot of people active really from government and funders. It is sad when things have to get so serious in order for things to start to move. And as you can see now, the publications in terms of neuroscience and addiction have really gone sky high. And it is also mentioned in a lot of strategic plans. And as I've said, so we are really aware that neuroscience is now seen as core. Next slide, please. However, there are some people who are critical of the theory, and Wayne Hall is I know him quite well, and he's often we've often had robust discussions, I think, about the place. So this was a review written a few years ago now, published in Lancet Psychiatry. Is it supported by the evidence, and has it delivered? And what I put in here in red is the brain disease model is not supported to the extent the advocates suggest. So he's not saying there isn't support, it's to the extent. And his feeling is really hasn't delivered more effective treatments, and its effect on public policies has been really modest. So for me, it's not really, he's not critiquing that neuroscience research isn't part of it, but what he's critiquing is its importance, and he feels that it's now become a major influence on popular discourse without some of the granularity. Next slide, please. So one of the criticisms said was about public policies. So one of the worries was the shift would be away from public health, which I absolutely agree are really, really important. To me, it's not an either or, it should be both. But I guess, as we've heard in previous talks, often it is either or. Public health taxation, the restrictions on advertising, the limits on who and when can buy is absolutely critical. But there are, even the best public health policies in the world, there will still be people that require treatment. And for me, as I've said, I'm focusing on those that have developed an addiction. And I do think the neuroscience has a really, really critical part to play. Next slide, please. And this is really the treatment. So he's saying that this was the list, new drugs, this is what would be, we would have vaccines, we would have, you know, fancy new agonists and antagonists, we'd have the DNA, etc., etc. And I would absolutely agree with him that actually few new drugs have been approved for treatment of addiction the past 2 decades. I would argue that actually the funding and the development hasn't been there. I've described our ICANN. We've looked at D3, it looks really promising, but it's still sitting on the shelf. But even when we get the new formulations into our clinic, their price structure means that we can't afford them. So we've had the ridiculous situation where buprenorphine, an opiate agonist, partial agonist to treat addiction, safer than methadone, was too expensive by some services to deliver it. So we have a safer drug to give heroin addicts. We can't give it because it's priced. Next slide. And the next thing is lofexidine. So this is an evidence-based drug. It's approved by NICE based on preclinical evidence. It's an alpha adrenergic agonist based on, going back to that slide of the adrenaline system being very important in withdrawal. It's not been available since 2018. We don't know when we get it. It's just been approved. It was approved almost the same time as it's become unavailable in this country. We don't know when we're going to get it back again, but this is a drug that you can give to treat opiate withdrawal. So you don't have to give an opiate. It's safe to give. We haven't got it available. Where's the hoo-ha song and dance about it? So even when we have the drugs available, technically, we can't give them because actually they're not available in this country and or they're priced out. Next slide, please. So because of the absence of lofexidine, I went back in the neuroscience of the thing, and actually I found there's a potential role for GABA B, and we have a drug called Bethlem, which is an agonist, and maybe that would be helpful in treating opiate withdrawal. And I'm just showing some preclinical evidence that clonidine, another alpha agonist, is very similar to baclofen, and it was going to be helpful and reduce withdrawal. Clinical studies many years ago studying baclofen is also good anxiolytic, it's good sedative. So we have all the drugs, and MRC are now funding us to, have all the evidence. So we're now funding, MRC are funding a study. We're now looking at to see if we can have opiate withdrawal. So this is where neuroscience can inform and take us through. Next slide, please. And NIDA now has a top 10 list. You can see on that list, there's the D3. I'm also looking at several other agonists on there, compounds on there, GABA B. So things are moving, but they're moving a little slow. Next slide, please. What have we got that we can bring into the clinic now? Well, I was involved in a study of ketamine assisted psychotherapy treatment of alcoholism that's just being published in American Journal of Psychiatry. What you can see here from the yellow and green bars is that if you had ketamine assisted psychotherapy, that boosted the impact of both those psychotherapy. One was education and one was much more about psychological therapy. So ketamine is looking very promising. We've just applied to NIHR to do a bigger study with a wider group of participants. And you may have heard about the cannabinoids and their potential, particularly treating cannabis, but others. So we have alternative approaches. We're just now trying to get them into the clinic. And next slide, please. And of course, I'm sure David Nutt will talk about this later, but we have the psychedelics. We have the MDMA study from Ben Sessa and David in Bristol, showing with the red line the outcomes of the normal outcomes of their alcohol withdrawal program compared to the black line, the reduction in amount of drinking if people had ecstasy psychotherapy. And the whole area of psychedelics and what it's trying to do and help us understand the brain, but also maybe it's unlocking some of these very rigid structures in the brain and connections that help addicts recover from their addiction. So it is a watch this space. Next slide, please. I'm aware I'm getting close for time. The other thing that is really happening is we're bringing everybody together. So we're bringing data sets together. And that's giving us a lot more power, and my group is part of many of the Enigma addiction. But what we're trying to do is we're putting together tasks, we're putting together the clinical information, we're putting together genetics, and then we're trying to see, what are the characteristics of people. So this is a fantastic new addition of collaboration across the world. Next slide. So I just wanted to what is the role of the sort of neuroscience really in national policy? Hopefully you get the importance. So next slide, please. We've got clinical guidelines, clearly a massive impact in terms of the neuroscience and clinical trials. So, I mean, that's the sort of a given through from NICE to the BAP guidelines. And the next slide, please. But of course, we need more. Next slide. And so who are we going to have to persuade? Well, of course, we need to persuade. Next slide coming up, please. the politicians. So what I find interesting when you look at the politicians, even those that have admitted it, most of them said that it was with regret or it didn't have an effect. Of course, alcohol is a drug, and we know that actually that causes major issues. And a lot of people have had siblings or parents with drug and alcohol, and often that does seem to be more pervasive and persuasive of their opinions. But next slide, please. But what does this impact about? Look at it. So we had our 10-year strategy report published just in the last few months. And the Prime Minister really focused on the criminal aspect and levelling up. So we've got to tackle drugs. So this was Boris here in his police on an early morning raid in the north of England. So despite that, within this drug strategy, there was about treatment. Next slide. But you would never have known from all of the publicity. And the investment they're going to put in, look at the millions they're going to put in over the next 3 years. And they've got huge targets, more treatment places. You know, we haven't seen this in years. What this will do will bring us back to about 12 years ago when service cuts went down, were started to be implemented. So services have been cut over the last decade or so by about 30 to 50%. This will take us back to where we were over a decade ago. It's welcome, but we still need more. Next slide. But what we need is it to go into the evidence, and they're focusing on drug-related deaths. So one of the things we can give is naloxone, which is an opiate antagonist which will bring people out of an opiate overdose. We can give injecting rooms, all of those things. It's evidence, but actually the governments and the ministers often don't want to lead with the evidence. It's been incredibly hard. So I've just given Scotland there. In Scotland, they would like to have drug consumption rooms to have safer injecting. And look at the number of deaths. They really are in a league of their own, sadly. But the ministers and the UK and the Westminster will not allow that. So Helen mentioned about, and also previous speakers, we've got to be led by the evidence. The evidence is there, but the politicians don't always follow it. Next slide. Can you just clip over? Next slide. The reason I just wanted to mention about neuroscience to come back to opiate overdose deaths is because there are other mechanisms available that we know from animal literature, from preclinical to clinical. So you don't have to look at the opiate system. We can look at other systems, but we're not looking at them because there isn't the funding and the interest in it. So we have got to use our knowledge of neuroscience to understand how we help the addicts and protect their breathing, because it is the opiate-related respiratory death that kills them. Next slide, please. So I think it usually comes up, but have we got the staff? Well, I've already mentioned the service cuts, and we don't have the services at the moment, and we don't have the staff, and because we don't have a neuroscience and research competent addiction, unfortunately. So we do hope the new strategy will attend with that, but you may be aware that the trainee posts have plummeted. And so there will be a whole generation of consultants coming through with really no addiction experience, which will not be good. Next slide, please. We do need the funding of the strategy. I've mentioned in my bio that I lead the MARC scheme, which is an MRC funded. We're still waiting a refreshment of the MRC. But when you try and look in research funding bodies for addiction strategy, it's not found wanting. And an MQ did a recent review of funding in mental health. As you can see, substance misuse doesn't do too badly, but actually most of that was about etiology. And I've wrote a commentary about will always be the Cinderella of medicine. So next slide, please. What is brilliant is that Dame Carol Black's really influential report that's put all that money into clinical services also highlights, as I put in red here, research, and particularly pharmacological research, and particularly links with pharma industry. So whilst the millions have come into the service, what we now need to see is the funding coming into the MRC, NIHR, Wellcome, whoever, to fund, to really change the landscape. So next slide, please. So as I've said, that was my sort of slide, almost of my career, about how much addiction research has come in neuroscience. And really what I hope I've shown you is the important role of neuroscience and influencing addiction policy. And what we need is not only policy in terms of the evidence base in clinic, we also need to be able to generate the evidence in order to influence policy, particularly treatment of addiction. Next slide. this is just to thank my main collaborators in terms of ICAM, huge number that you can see here. And thank you, I'll end there. And apologies for going over slightly in 5 minutes for Q&A. Thank you.